Welcome back to the deep dive. If there is one singular mission that, well, really defines modern medicine, it's providing safe care. Today we're taking a deep dive into that fundamental concept, patient safety, and we're pulling directly from the authoritative analysis in Harrison's Principles of Internal Medicine.
Yeah, this is such a critical topic for really anyone involved in healthcare. Safety isn't just some side project. It's the absolute foundation.
Right.
And Harrison's makes it clear. Safety and quality, they're the two core dimensions of how we should think about healthcare today. And the tough reality is we have to get better at both. Dramatically better.
And that push for improvement is coming from everywhere, isn't it? It's not just our own ethical compass anymore.
Exactly. The public demands transparency, they want to see measurable results, and frankly, accountability when things go wrong. Plus, and this is huge, the money is following. Payment for healthcare services. It's getting tied more and more to how well systems actually perform on safety and quality. So you really can't afford to ignore safety, not ethically, and increasingly not financially either.
We're focusing specifically on the chapter dealing with safety and quality in Harrison's, but maybe we should start by pinning down these two terms, safety and quality, because they often get tangled up.
They definitely do. They're related, no doubt, but they are distinct. And a lot of this clarity comes from those really important reports from the Institute of Medicine, the IOM, years back.
Ah, the IOM reports.
Yeah, they set up a clear hierarchy. Safety, that's the first part of quality, the absolute prerequisite. You have to have safety before you can even talk about quality.
Okay, so if quality is the big goal,
Mm-hmm.
delivering the best, most effective care, safety is like the starting block, the non-negotiable baseline.
That's a perfect way to put it. Safety is strictly about preventing harm, making sure our treatments, our processes don't actually hurt the patient. Quality, though, that's broader. It's about getting the best possible clinical benefit, making sure care is effective, timely, fair, all of that.
I see. So safety feels more concrete. If I cause an injury, that's a clear safety fail. Quality is more about the overall positive outcome.
Right. And safety often grabs the headlines, the public concern, because harm is immediate, it's tangible. But interestingly, improving the overall quality of care, like, say, consistently using evidence-based guidelines for managing diabetes, that might actually give a bigger net clinical benefit in the long run, even if it's less dramatic than preventing one awful event.
But you can't reach that high quality without the safety net firmly in place first.
No way. Safety first. So for today's deep dive, we're zeroing in just on that prerequisite, safety in healthcare. We'll get into the psychology behind errors, the systems thinking, the pretty stark statistics on adverse events, and what strategies actually work for prevention, all guided by Harrison's.
Okay, let's dive in. We really have to start with a fundamental truth about being human. We all make errors all the time.
We absolutely do. And safety theory, it demands we accept that. You can't design a safe system based on the idea that people will be perfect. It just doesn't work.
Right. So the system has to be built around the fact that errors will happen. And the first crucial step is knowing the difference between types of errors. Because, like you said, how you prevent them is totally different. Harrison's lays out that classic split. Slips versus mistakes. Let's tackle slips first. What's a slip?
Okay, a slip. That's an error in, execution. It happens when you're doing something routine, something semi-automatic. Your brain's kind of on autopilot. The classic example, the one Harrison's uses, is you're driving home, you fully intend to stop at the grocery store for milk, right? And then suddenly you're pulling into your own driveway. You just blew right past the store without even thinking about it.
Oh yeah, I've done that.
We all have. Your driving actions were fine, you were safe, but your intention failed. That's a slip.
And in a hospital setting, that often happens because of interruptions.
Right. Exactly. You go to sign off on an important medication order, your pager goes off with something urgent, you handle that, and then you just forget to go back and finish the original order. Because it was a routine task, not fully engaging your conscious mind, the interruption just wiped it. Slips are everywhere in busy hospital work.
Okay, then there are mistakes. These feel different, maybe more serious, because they involve conscious thought.
They do. Mistakes are errors in planning or judgment. They happen in situations that are new or complex or just not routine. Situations where you have to actively think, calculate, decide. The example Harrison's gives is, say, a doctor dosing a medication they aren't very familiar with. That takes real conscious effort, looking up the guidelines, figuring out the dose based on weight or kidney function, making a judgment call. If you get that wrong, it's a failure in your planning and your conscious thought process. That's a mistake.
So thinking about prevention, if I see slips happening, I need to build in things like reminders, maybe checklists, or design the workflow to minimize interruptions, force functions.
Exactly. Environmental fixes, hard stops.
But if I see mistakes happening, the solution is different. It's more about better training, maybe simulation, or having really good decision support tools available.
Precisely. You're hitting the root cause of that specific type of cognitive failure. And making that distinction is key because it shifts us away from just blaming the person they weren't careful enough, and pushes us towards systems thinking, which is really the foundation for improving safety.
Right. Systems theory. That idea that it's usually not about a bad apple, one person being malicious or incompetent. It's about the system itself having flaws.
That's the crucial mindset shift. We have to assume that, look, the vast majority of doctors, nurses, pharmacists, everyone, they're dedicated, they're trying their best. So when things go wrong, instead of pointing fingers, we need to look at the system that allowed that failure to reach the patient.
And that's where the Swiss cheese model comes in. Such a powerful visual for this.
It really is. Let's break it down for anyone who hasn't seen it. Imagine you've got some kind of hazard, let's say, a potential medication error. And on the other side, you have the patient potentially getting harmed, the loss. In between, you stack up slices of Swiss cheese.
Okay, so each slice is a defense.
Exactly. Each slice is a barrier, a safeguard we build into the system. Things like double checks, protocols, computer alerts, pharmacist reviews, nurse checks at the bedside. All these layers designed to catch an error before it reaches the patient.
But Swiss cheese has holes. So the holes are the failures in those defenses.
Right. And the holes are really important to understand. They come in two main types. The ones we usually see, the immediate ones, are called active failures.
Yes, the slipper mistake we were just talking about. The person right there making the error.
Yeah, the nurse grabbing the wrong vial, the doctor writing the wrong dose. That's an active failure happening right at the sharp end, the point of care.
But the model says those aren't the only holes. There are these other ones.
Yeah.
Latent conditions.
Yeah. Yes. And these are often the real culprits. Latent conditions. Harrison's calls them resident pathogens, like dormant weaknesses just sitting there in the system waiting.
So give me an example. What's a latent condition?
It could be anything from poor equipment design, maybe two critical drugs have look-alike packaging because of a purchasing decision, or chronic understaffing that leads to constant fatigue, or maybe inadequate training on a new piece of technology. These things don't cause harm directly, they just create the conditions for an accident.
They make the holes bigger or more likely to appear in the defensive layers.
Precisely. They're like hidden traps. Now, an accident, a loss, only happens when, by bad luck mostly, the holes in multiple slices of cheese momentarily line up.
Ah, I see.
So that hazard, the potential error, can travel straight through all the defenses because each one failed in just the right sequence. Maybe the doctor made a slip because they were fatigued, latent condition, understaffing. The computer alert didn't fire because of a software bug, latent condition, poor maintenance. And the nurse missed the check because of an interruption, latent condition, workflow design.
Okay, that makes it really clear why just blaming the doctor or the nurse at the end is missing the point. The system had multiple failures lined up.
Exactly. So the goal of good system design isn't just to make people try harder. It's twofold. One, design a system to make those active errors less likely in the first place, better interfaces, less fatigue, fewer interruptions. And two, build stronger defenses, more layers of cheese, and make sure those holes are unlikely to ever align. You need redundancy. You need systems that actively catch errors when they inevitably happen.
Okay, so we have the theory. Errors happen, systems fail. Now let's get concrete. What are those factors in the hospital environment that are constantly poking holes in our Swiss cheese? Harrison points out 5 big ones that are pretty much everywhere in healthcare. Let's start with the one that gets a lot of attention. Fatigue.
Oh, fatigue is a huge one. The evidence is just overwhelming. Harrison's makes the comparison to industries like trucking, where we know longer shifts directly correlate with more accidents. It's the same in medicine.
And there's that key study on residents, house officers, that really highlighted the risk of long shifts.
Yeah, that study was really impactful. It looked at ICU staff and found that residents were about 1/3 more likely to make significant medical errors when they were working a traditional 24-hour-plus continuous shift compared to shifts where they'd had a chance for about 8 hours of sleep the night before.
Wow, a 33% jump in errors just based on the shift schedule?
It's a massive difference, and that finding was really a major driver behind the ACGME, the Accreditation Council for Graduate Medical Education, bringing in the 80-hour workweek rules.
Which was definitely a positive step, right?
Yeah.
Limiting total hours. But did it completely fix the fatigue error link?
Well, not entirely, and Harrison's points this out. The 80-hour cap was important. It limited the total workload over a week, but it didn't fully get rid of the single highest risk element.
Right.
Those really long extended duty shifts, the 24 or 28-hour calls. So you could still be technically compliant with the 80-hour rule, but if you had one or two of those marathon shifts within that week, your risk during those specific shifts remained dangerously high due to the profound cognitive fatigue, the microsleep.
So it's not just the total hours, it's the intensity and duration of continuous work without sleep. That specific latent condition wasn't fully addressed.
Exactly. The work hour limits helped, but the structure of those extended shifts remains a vulnerability.
Okay, factor number 2, stress and heavy workloads. These often go hand in hand with fatigue, I imagine.
They absolutely do. It's almost intuitive, right? Errors are just more likely when things are chaotic, high pressure. Think about running a code, a cardiac arrest, or managing a patient who's crashing. Your cognitive load is maxed out. You can get tunnel vision, miss subtle cues.
So how do systems defend against that kind of unavoidable stress? You can't make a code not stressful.
You can't. So the defense relies on standardization and process. You implement really rigid protocols like ACLS, advanced cardiac life support. You drill them, you use checklists. The idea is that the team can rely on muscle memory, on the established procedure, rather than having to think creatively or remember complex steps under extreme pressure.
Leaning on the system, the protocol, rather than individual brilliance in the moment.
Precisely. And even just acknowledging the stress, saying, okay, this is a high-risk moment, let's slow down and stick to the protocol, that itself is a safety strategy.
Okay, the third factor. This one everyone experiences. Interruptions.
Oh, interruptions. They're constant in healthcare, especially for nurses and doctors. Pagers, phones, colleagues, family members. It's relentless. And the big danger, clinically speaking, is what's called reversion failure.
Meaning you forget to finish what you started before the interruption.
Exactly. You start a task, get interrupted, deal with the interruption, and then you either forget to go back to the original task altogether, or you restart it incorrectly because your short-term memory of where you were got scrambled.
Can you give a quick clinical example?
Sure. A nurse is programming an IV pump for, say, heparin, a high-risk drug. They're halfway through entering the rate. Someone asks an urgent question. They answer it. They come back to the pump. And maybe they forget to do the required independent double check, or they accidentally skip a step in the programming sequence because they lost their place. That's how dangerous interruptions can be with critical tasks.
So the solutions involve trying to minimize them, maybe create no interruption zones for certain tasks, and maybe better ways to signal urgency?
Yes to both. Protected time or space for things like medication prep is crucial, and we need better communication systems so people can flag if something is truly life or death urgent versus something that can wait 5 minutes, allowing the person being interrupted to manage their workflow better.
Okay, fourth factor, complexity. This feels like it's just getting worse with more technology, more data.
It is a huge challenge. Clinicians are just drowning in information. You've got continuous vital signs, streams of lab results, imaging reports, electronic health record notes. It's a flood. The problem is most of it, maybe 99%, is just noise in terms of immediate action needed. But somewhere in that flood is the 1% signal that's critical.
Finding the needle in the haystack.
Exactly. And when the system generates too much data or too many alerts that aren't truly important, you get alarm fatigue.
Yes, alarm fatigue. We hear that a lot.
It's a major safety hazard. If monitors are constantly beeping for minor things, or the electronic record throws up dozens of low-priority warnings, people just become numb to them. They start overwriting them, ignoring them, clicking through them without thinking.
So a genuinely critical alert, maybe a serious drug interaction, gets missed because it's lost in all the noise.
Precisely. The system has inadvertently trained the user to ignore its own warnings.
So the answer isn't just more information, it's smarter information display.
Absolutely. We need better system design. Tools that filter and synthesize data that only alert you for specific combinations of concerning findings, or when a value crosses a truly critical threshold. Making the alerts meaningful again so when one fires, you know you need to pay attention.
And the fifth factor, which kind of ties everything together and often makes things worse, transitions of care.
Transitions are consistently flagged as super high-risk points. Handoffs between providers, transfers between units, discharge from the hospital, anytime the responsibility for the patient shifts. And ironically, things like the 80-hour work week, while reducing fatigue, actually increase the number of transitions needed.
So what typically gets lost or messed up during a handover?
Often it's the nuance, the context, the why behind decisions, or maybe the contingency plans, the things the outgoing provider was worried might happen. Simple information transfer can fail, but even more subtle things, like the rationale for a specific dose or a gut feeling about a patient's trajectory, can get dropped.
And Harrison emphasizes using structured tools for this.
Yes, absolutely critical. You can't rely on just a casual chat. You need standardized handoff protocols, things like SBR, situation, background, assessment recommendation, or other structured mnemonics.
What makes a handoff structured?
It means there's a defined template. You have to cover specific things: the patient's current status, key events, what needs to be done next, what to watch out for. And crucially, it often involves a readback or closed loop communication where the receiving inviter has to summarize their understanding back to the sender.
Okay, ensuring the information was not just sent, but received and understood.
Exactly. Without that structured process, transitions remain a huge vulnerability, a major source of those holes lining up.
All right, we've got the theory of error, the system factors that enable it. Now for the really sobering part, the numbers. How often do these failures actually injure patients? Let's talk about the epidemiology of adverse events.
Right. And historically, most of the big foundational studies looked at inpatients, people in the hospital. We have less data, though it's growing, on outpatient settings. But the study that really opened everyone's eyes was the Harvard Medical Practice Study, the HMPS.
And we need to be clear on how they defined an adverse event, an AE, because that determines what they counted.
They were very rigorous. An AE was defined as an injury that was caused by medical management. So, importantly, it wasn't just the patient getting sicker from their disease. It had to be harm from something we did or failed to do.
Right.
And that injury had to have real consequences. It caused death or disability when the patient left the hospital, or it made their hospital stay at least 2 days longer than expected.
So if you come in with pneumonia and get worse, just because pneumonia is bad, that's not an AE. But if you get the wrong antibiotic, develop kidney failure because of it, and stay in the hospital an extra week, that's an AB.
Exactly. Harm from the care itself. And the results from the HMPS, which looked at records from New York hospitals back in the 80s, were just shocking at the time.
What did they find? What was the rate?
They found an adverse event rate of 3.7%. Nearly 4 out of every 100 patients admitted suffered an injury caused by their medical care. That alone was a wake-up call. Harm wasn't rare, it was common.
But the really stunning part was the preventability, wasn't it?
That was the kicker. They judged that 58% of those adverse events were preventable.
58%. Almost two-thirds of the harm could have been avoided.
Yeah, it was a huge finding. It strongly suggested that these weren't just unavoidable complications or isolated mistakes. It pointed squarely at systemic problems, flaws in the processes of care, that Swiss cheese model in action.
And this wasn't just a New York problem, right? Other studies found similar things.
That's right. Harrison's notes that later studies done in Colorado and Utah basically replicated those findings. Similar rates of AEs, similar rates of preventability. It confirmed this was a widespread systemic issue across the U.S.
Okay, fast forward from the HMPS to more recent times. Harrison cites studies suggesting the frequency of harm might now be approaching 1 in 4 hospital admissions. That sounds astronomically higher.
It does sound way higher, moving from roughly 4% to closer to 25%. It's a startling number, and we need to unpack it carefully. It doesn't necessarily mean care itself has gotten 5 or 6 times more dangerous.
Okay, so what's changed?
A big part of it is that our detection methods have gotten way, way better.
How so? How are we finding more harm now?
Well, the original studies relied heavily on manual chart review people reading through stacks of paper records, which is slow, expensive, and you miss things. Now we can use the power of electronic health records. Researchers use automated methods, looking for specific triggers.
Triggers. What's an electronic trigger?
A trigger is basically an electronic clue in the patient's record that suggests an adverse event might have happened even if no one reported it. Things like a sudden order for an antidote medication like Narcan for an opioid overdose, or vitamin K for over anticoagulation, or an unexpected transfer to the ICU. Or maybe certain patterns of lab tests ordered to investigate a potential complication.
So you're searching for the signs or the consequences of harm in the data rather than just relying on someone writing adverse event in the chart.
Exactly. It's proactive, automated surveillance using the rich data in the EHR. So we're finding more of the harm that was probably happening all along but was previously hidden. That improved detection, combined with the fact that care has become more complex, sicker patients, more medications, more procedures, likely explains much of that jump to the 1 in 4 figure.
That makes sense. It's a combination of better tools, finding more, and maybe increased complexity, creating more opportunities for error. But Harrison's does offer a bit of hope within that stark number.
It does. It makes the important point that while the overall detected harm rate is high, we have made progress in specific areas. Things like certain hospital-acquired infections, bloodstream infections from central lines, CLAB-SI, or urinary tract infections from catheters, CAUTI, those have demonstrably decreased because of very focused, systematic prevention efforts, like checklists.
Okay, so targeted efforts can work. Let's break down the types of errors that cause the most harm so we know where to target those efforts. Going back to the original HMPS data, what were the biggest categories?
Overall, the most common category was adverse drug events, ADEs, medication errors. They accounted for 19% of all the AEs they found.
Almost 1 in 5.
Yep. Next came wound infections, often post-surgical, at 14%, and then technical complications from procedures at 13%. And it's worth noting, almost half of all the adverse events they identified were linked somehow to a surgical procedure.
Okay, but if we focus just on the non-surgical side, the medical side of the hospital, which is a lot of what internal medicine deals with, how does the breakdown look there?
Then ADEs become even more dominant. Among the non-operative errors, adverse drug events were responsible for a whopping 37%.
Over a third.
Yeah. After that came diagnostic mishaps, things like misdiagnoses, wrong diagnoses, delayed diagnoses at 15%, and then therapeutic mishaps, problems with non-medication treatments at 14%.
So the message seems pretty clear. If you want to make the biggest impact on safety for non-surgical patients, you absolutely have to tackle medication safety. ADEs are the elephant in the room.
Without a doubt.
So let's drill down on ADEs. What do we know about how often they happen inside the hospital now?
The commonly cited figures suggest that somewhere between 6% and 10% of patients admitted to U.S. hospitals will experience an adverse drug event during their stay. But again, how you measure it really matters.
Right, because people don't always report them.
Exactly. We know spontaneous reporting, relying on doctors or nurses to voluntarily report an ADE, is terrible for measurement. It catches maybe 5%, probably less, of the actual events.
So researchers use other methods like chart review or those computerized ADE monitors looking for triggers.
Yes, and the computerized monitors search the electronic databases for those signals, antidote orders, specific lab tests, abrupt medication stops. Harrison's highlights a really important point here. Studies that combine methods say detailed chart review plus automated trigger tools consistently find a much higher underlying rate of ADEs than studies using just one method alone.
So even our best detection methods are probably still missing some. That 6–10% figure might be an underestimate.
It's very likely an underestimate of the true burden. It just emphasizes how pervasive medication-related harm is.
And the danger doesn't end when the patient walks out the hospital door, right? What about ADEs in the outpatient world?
Yeah, the risk continues, definitely. Drug-related injuries are actually quite common outside the hospital too, though maybe often less severe than the ones landing people in the ICU. One study Harrison's mentions involved researchers actively calling patients after clinic visits to ask about medication problems. They found a rate of 21 ADEs per 100 patients per year.
Wow, 21 per 100 patients per year. That's substantial.
It is, and even in that outpatient setting, they judged about a third of those ADEs were preventable. So that's low level, but potentially harmful medication issues happening in everyday life.
And there's a particularly dangerous period right after discharge, what you call the post-discharge cliff. Why is that specific time so risky?
This is where a couple of those big risk factors we talked about collide. Transitions of care and ADEs. Patients leave the hospital, often with a bag full of new meds. Maybe some old ones were stopped. The instructions might be confusing. The follow-up isn't clear. It's a perfect storm.
And the data reflects that.
Very much so. One study specifically tracked patients right after they left a medical service in the hospital. They found an adverse event rate of 19% in the immediate post-discharge period.
Nearly 1 in 5 patients hurt shortly after going home. That's alarming.
It's deeply concerning. And of those post-discharge events, again, about a third were deemed preventable, and another third were considered ameliorable, meaning the harm could have been made much less severe if caught earlier.
And what was the main cause of that post-discharge harm?
Once again, leading the pack. Adverse drug events. Issues like problems with blood thinner dosing, confusion about antibiotic courses started in the hospital, side effects from new heart medications. It highlights a massive failure in that transition process, especially around medication reconciliation and patient education.
So that handoff from inpatient to outpatient is just critically flawed, it seems.
It's a major, major gap in the safety net. Improving safety means focusing intensely not just on the ICU, but on nailing that discharge transition perfectly every time.
Okay, if this sets the stage perfectly for prevention, we know the scale of the problem may be 1 in 4 patients harmed. ADEs and infections are huge contributors. Transitions are weak points. So what actually works? What are the high-impact prevention strategies, especially inside the hospital, that Harrison's highlights as being proven?
Well, as you'd expect, given the data, a lot of the focus and the best evidence is around preventing nosocomial infections, hospital-acquired infections, and those adverse drug events. And some of the most powerful strategies are actually quite systematic, even if low-tech.
Let's start with maybe the most famous low-tech, high-impact example,
Yeah.
checklists.
The humble checklist. Its impact, particularly in intensive care units, has been absolutely revolutionary. We're talking about preventing really serious, life-threatening complications like CLABSI, bloodstream infections from central lines, and VAP, ventilator-associated pneumonia.
And the power isn't necessarily that the steps on the checklist are secret knowledge, right? It's about making sure they happen every single time.
That is exactly it. Consistency. The checklist forces the reliable execution of a handful of specific evidence-based actions that are easy to forget or skip when people are busy, stressed, or interrupted. For example, before putting in a central line, the checklist ensures things like proper hand washing, using the full sterile barrier, using the right antiseptic on the skin, and checking the site daily. Simple steps, but easily missed.
And when you enforce that 100% compliance through the checklist,
The results are dramatic. Harrison's mentions the example of the Keystone Initiative in Michigan, where implementing these simple checklists across ICUs statewide led to what they call an extreme reduction in CLEB-SI rates. It proved that these often devastating complications are highly preventable with systematic, standardized approaches.
a powerful demonstration of systems thinking applied. Now let's shift from low-tech to high-tech. Probably the single biggest technological intervention for medication safety is computerized physician order entry, or CPOE, especially when it's linked with clinical decision support, CDS.
Right. CPOE itself is foundational getting rid of handwritten orders, which are notoriously prone to errors from bad handwriting or ambiguous abbreviations. Just ordering electronically is a big step. But the real magic happens when you pair CPOE with good clinical decision support. That combination has been proven to significantly reduce the rate of serious medication errors, the ones that actually hurt patients or have the clear potential to cause harm.
Is there a number on that reduction? How much does it help?
There's a well-known study cited in Harrison's that found CPOE, even with relatively basic decision support, cut the rate of serious medication errors by 55%.
Wow, cut them by more than half. That's huge.
It's a massive impact on the most dangerous types of medication mistakes.
So how does it work? What exactly does the CPOE system do to prevent those errors?
It builds in several layers of defense. First, it forces orders to be complete. You have to specify the dose, the route, the frequency. It won't let you submit an incomplete order, preventing that kind of slip. Second, it enforces standardization using approved drug names and standard dosing units. Third, and this is where the power really lies, it performs instant checks against the patient's electronic record.
Checks for what specific?
The crucial stuff. Allergies, it flags a drug the patient is known to be allergic to. Drug interactions, it warns if you're ordering a drug that dangerously interacts with another medication the patient is already on. And really importantly, drug laboratory interactions, for instance, warning you if you're ordering a drug that needs dose adjustment because the patient's kidney function is poor based on their latest lab results.
And the clinical decision support, the CDS part, makes those checks even smarter.
Exactly. CDS is the intelligence behind the scenes. It uses rules and algorithms to provide more specific guidance. Harrison's details a great study on renal dosing, adjusting drug doses for patients with kidney problems. Without CDS, doctors got the dose right only about a third of the time. With CDS providing recommendations, accuracy jumped to about 2/3.
That's a big improvement in correctness.
Yeah.
Did it actually affect patient outcomes?
It absolutely did. In that study, the patients who got the appropriate renal dosing because of the CDS alerts were actually discharged from the hospital on average half a day sooner.
Wow, so better safety led directly to better efficiency and outcomes.
It's a perfect example of how safety isn't just about preventing bad things, it's about enabling good things too.
Now, CPOE itself is pretty much everywhere now, right? But Harrison's notes a catch with the CDS part.
That's right. CPOE adoption is near universal in U.S. hospitals, over 95% by 2019. The problem is the quality and intelligence of the clinical decision support that's built into these systems varies hugely. And sometimes it's frankly poorly designed.
Leading back to that problem of alert fatigue.
Exactly. If the CDS system generates too many irrelevant warnings, too many low-priority alerts that interrupt workflow without adding much value, clinicians just start ignoring all the alerts, including the critically important ones. It completely undermines the safety benefit. So the challenge now isn't just implementing CPOE, it's implementing smart CPOE with well-designed, highly relevant decision support.
Optimizing the technology so it's a helpful co-pilot, not an annoying backseat driver.
That's a great way to put it.
Okay, so CPOE and CDS help with the ordering part. What about ensuring the right drug gets to the right patient at the bedside? The administration phase.
That's where barcoding technology, linked with an electronic medication administration record, EMAR, comes in. This is really the final safety check right before the medication is given. The goal is to electronically verify the 5 rights of medication administration.
Remind us of the 5, right?
Right patient, right medication, right dose, right route, and right time.
And how does barcoding help confirm those?
Well, the nurse scans the barcode on the patient's wristband that confirms right patient. Then they scan the barcode on the medication package itself. The system checks that scanned medication against the patient's EMAR, their electronic list of current orders, confirming it's the right drug, right dose, right route, and that it's being given at the right time.
So it creates a hard stop if there's a mismatch, like trying to give patient A's medication to patient B.
Exactly. Or if the nurse accidentally grabbed the wrong drug from the medication drawer, it prevents those administration errors. And the EMAR provides a perfect, time-stamped electronic log of every dose given, which is great for tracking and auditing.
Okay, and for particularly high-risk medications, especially IV drugs, there's another layer, smart pumps.
Yes, smart infusion pumps are a critical technology. They have built-in drug libraries. These libraries contain preset dosing limits, both minimums and maximums, hard limits you can't override, and soft limits that trigger warnings for specific high-risk medications.
So if a nurse accidentally programs in an extra 0 for a heparin dose,
The smart pump should catch it. If the rate or dose being programmed falls outside the predefined safe limits for that specific drug in the library, the pump will alarm, force the user to confirm, or in the case of a hard limit, simply refuse to start the infusion. It's a final electronic safeguard against potentially catastrophic IV dosing errors.
makes sense. So we've got technology for ordering, technology for administration. What about the human processes and organizational rules that back this all up? Mandates from groups like the Joint Commission.
Yeah, regulatory and accrediting bodies play a big role by setting standards, and many of these focus on clear communication and reducing ambiguity, which we know are sources of error.
One key procedure they mandate is readback.
Right, readback is crucial because, despite all the tech, verbal orders still happen in emergencies, in the operating room, sometimes over the phone. The rule is simple. When you receive a verbal order, you must write it down immediately and then read it back word for word to the person who gave it.
To close the communication loop.
Exactly. The sender has to confirm, yes, that's correct. It prevents errors from mishearing drug names that sound alike, or numbers getting transposed, or just bad phone connections. Simple, but very effective.
And the other big procedural push is around standardization, especially of abbreviations and dose notations.
This is huge for preventing errors caused by ambiguity. It means hospitals must have a list of approved abbreviations and ban the use of dangerous, easily misinterpreted ones. It also involves standardizing how doses are written.
Like the rules about leading and trailing zeros.
Yes. Always use a leading 0 before a decimal point for doses less than 1, like, 0.5 milligram, not 0.5 milligrams, which could be missed. And never use a trailing 0 after a whole number, write 5 milligrams, not 5.0 milligram, because the decimal could be missed and read as 50.
And avoiding things like U for units.
Absolutely. That's the classic example Harrison's gives. U for units can easily be misread as a 0. So 7U might be mistaken for 70. Using the full word units prevents that potentially fatal tenfold overdose. Standardization eliminates these known risks.
Okay, we've covered the theory, the scale of the problem, and a lot of proven solutions, both technical and procedural. The last piece of the puzzle Harris discusses is measurement. And surprisingly, this seems like one of the biggest ongoing challenges. Why is it so hard to accurately measure safety?
It's incredibly difficult and expensive, mainly because while adverse events are common across the whole system, any specific type of event is usually quite rare for an individual patient or even a single hospital unit over a short time. And finding these rare events buried in complex medical records takes a huge amount of effort.
You need highly trained people reviewing lots and lots of charts.
Exactly, which is resource intensive. And the most common method hospitals rely on, spontaneous reporting by staff, we already know, is basically useless for accurate measurement.
All right, you said it only catches maybe 1 in 20 ADEs.
Yeah, something like 5%. So if a hospital is just looking at its incident reports, it's seeing only the tiny tip of the iceberg. Leaders trying to track safety trends or see if their improvement efforts are working are essentially flying blind. They don't have reliable data on the true baseline or the real impact of their interventions.
So if spontaneous reporting is out for measurement and manual chart review is too costly for routine use, what's the way forward? How can we measure safety better?
The future really has to be in leveraging those electronic health records more systematically, using automated surveillance methods.
Those electronic triggers again.
Exactly. Routinely programming the EHR system to actively search for those signals that suggest an AE might have occurred. The antidote orders, the ICU transfers, specific lab patterns, maybe even using natural language processing to scan clinician notes for keywords. The system can flag potential cases for a quick human review and confirmation.
Is this kind of automated surveillance common practice now?
It's getting there. It's definitely the most promising approach being researched and developed. It offers the potential for much more sensitive, continuous, and cost-effective safety monitoring compared to traditional methods. It could finally give hospitals a near real-time view of the actual frequency of harm.
Harrison's also mentions using claims data, like billing codes or malpractice data.
Yeah, claims data can be useful, especially for tracking complications after surgery, because surgical complications often have specific billing codes associated with them. For medical conditions, though, it's often less reliable. It's harder to tell from a billing code if a complication was a preventable adverse event or just an expected progression of a complex illness. So claims data usually needs a lot of validation for medical safety measurement.
So the bottom line on measurement right now is it's still a major weakness.
For the most part, yes. Except for a few specific, easily tracked things like patient falls with injury or certain healthcare-associated infections that have mandatory reporting, most hospitals still lack accurate, comprehensive information about the true frequency of many types of safety problems occurring within their walls.
That lack of visibility must be a huge barrier to improvement.
It absolutely is. But Harrison's makes a crucial point here. Regardless of how good or bad our formal measurement systems are, every single person working in healthcare still has a fundamental professional responsibility to report problems when they see them. Even if spontaneous reporting only touches 5%, that 5% is incredibly valuable. Those reported events, those near misses, they provide the real-world stories, the case studies, the lessons that allow the organization to investigate, to understand the system failures, and to learn.
So reporting isn't for measurement, it's for learning.
Exactly. It feeds the learning system. It turns an individual observation into organizational knowledge. It might be the only way a particular latent condition gets identified before it aligns with other holes and causes serious harm. That reporting culture is essential, independent of the measurement challenges.
Okay, that brings us toward wrapping up this really comprehensive deep dive. We've gone from error theory to epidemiology to solutions and measurement. Let's try to synthesize the main messages from Harrison's on the state of patient safety.
I think the overarching conclusion is stark, but also hopeful. The stark part is that the safety of healthcare can and must be substantially improved. When studies suggest nearly 1 in 4 inpatients suffers some level of harm, that's just not acceptable. We know much more about the risks inside the hospital, but outpatient and especially transitional care remain major areas needing more focus.
And the hopeful part is that we know what to do.
Yes. The path forward involves consistently, systematically applying the techniques we know work. Things like checklists for common procedures, fully leveraging information technology, especially CPOE, with smart, well-designed decision support for medication safety. But it's not just about tools.
Right, it's also about the system and the culture.
Absolutely. It requires broader changes, really digging into human factors analysis when errors happen, implementing robust team training like crew resource management principles from aviation, and most importantly, fostering a genuine, non-punitive culture of safety, where reporting errors is encouraged and seen as vital for learning, not for blaming.
And you mentioned earlier that the changing payment landscape might actually help drive these investments.
I think it's a necessary catalyst. As healthcare payment shifts more towards value-based care, paying for good outcomes and quality, not just volume, it becomes much easier for hospitals and health systems to justify making the significant investments needed in safety technology, in adequate staffing, and in training to build that safety culture. Safety stops being seen as just a cost and starts being recognized as a fundamental requirement for providing high-value care.
That makes sense. Okay, we've covered a huge amount of ground. To help everyone consolidate this, let's quickly recap the 5 most critical takeaway points from this deep dive into Harrison's section on safety in healthcare.
Okay, 5 key takeaways. First, error is human, but failure is systemic. Remember the Swiss cheese model. Most serious harm comes from latent system flaws, bad design, fatigue, poor training aligning with an active error. We need different strategies for preventing automatic slips versus conscious mistakes.
Second takeaway.
Second, harm is widespread and preventable. The old Harvard study found 58% of AEs were preventable. Newer studies using triggers suggest harm might affect nearly 1 in 4 in patients. Adverse drug events, ADEs, are the single biggest category, especially in non-surgical care and post-discharge.
Okay, third point.
Third, know the vulnerability points. 5 factors constantly weaken defenses. Fatigue, especially from long shifts, high stress and workload, constant interruptions, overwhelming complexity leading to alarm fatigue, and especially those dangerous transitions between providers or settings. These need active mitigation. Fourth, proven solutions exist and must be used. Simple tools like checklists drastically reduce infections. High-tech solutions like CPNOE with smart decision support are proven to cut serious medication errors by over half. Barcoding and smart pumps add crucial layers for administration. Standardization is key.
And the fifth and final takeaway.
Fifth, we can't fix what we can't see. The measurement gap. Current safety measurement is really difficult. Spontaneous reporting is grossly inadequate, capturing maybe 5% of ADEs. Hospitals often lack accurate data on their true harm rates. The future must involve better automated surveillance using electronic health record triggers.
Excellent summary. Those 5 points really capture the core of the challenge and the path forward. Now, before we officially close out this deep dive, we always like to leave our listeners with a final, provocative thought to mull over, based on our discussion today.
Okay, here's one to think about. We talked about how the 80-hour work week aimed to tackle fatigue, but Harrison's points out that the extended duty shift, that 24-hour plus call, remains the single biggest fatigue-related risk factor. So the question is, what truly fundamental structural or cultural changes, going beyond just capping total weekly hours, would be necessary to really solve the deep-seated problem of fatigue in demanding clinical roles, ensuring providers are cognitively at their best not just on average, but consistently, especially during those high-stakes overnight hours?
That really gets to the heart of redesigning the system around human limitations, doesn't it? Moving beyond historical models.
It does. It's a question about how we fundamentally structure training and service delivery to prioritize both patient safety and provider well-being simultaneously.
A profoundly important question with no easy answers. Thank you so much for guiding us through this absolutely essential deep dive into the principles of safety in healthcare straight from Harrison's.
My pleasure. It's a topic we all need to keep front and center.